is refreshment of what you're supposed to know if you work in outpatient setting, primary care setting, urgent care, and dealing with respiratory tract infection. So this is the outline of presentation. I'm going to be remind you about all of the RTIs. I will go briefly over the agents that cause RTIs in adults, such as virus, bacteria, fungi. I would talk about benefits and limitation of RTS lab diagnostic. Then we're going to talk about antibiotic use, misuse, and today challenges of AMR or AR, so-called. And then on the end, we're going to touch host immune response and 3 protein that can be used as diagnostic tool to help in primary care setting and hospital setting in distinguishing bacterial and viral RTIs. I strongly encourage you to stop me at any time of presentation with your question. Okay, so feel free. It's mostly intellectual stimulation, is journal club, which we can exchange, and we can, everybody from us, including me, learn something. Now, as you all know, or maybe you don't, let's talk about respiratory tract infection. We know that these are the major cause of visit in primary care setting. So they're caused by microorganisms. We have, of course, virus, bacteria, and fungi. And as you know, mechanism of entry is through the inhalation of aerosol, touching contaminated surface, and then microorganism invades mucus and cause epithelial destruction. And clinically, we have edema, hemorrhage, and sometimes exudate. We classify for all of the students here clinically RTIs in upper respiratory and lower respiratory infection, depending on the site of infection in the respiratory system. Now, easiest to remember is, we always say above lung and below lung. So difference in upper respiratory infection is that they're above lung. It's really 1 to 3 days post-exposure, and you will see typical patient with cough, sore throat, runny nose, nasal congestion, headache, low-grade fever, and they will complain about facial pressure. Sometimes they will sneeze, and some of them will report myalgias. You're familiar with diagnosis of upper respiratory infections such as rhinitis, pharyngitis, nasopharyngitis, sinusitis, laryngitis, epiglottitis. But what is important is that all of these diseases cost 10 million outpatient appointments per year. So we see a lot of patients with upper respiratory infection. Majority of them are kids. We see it or practice kids above 4 years, and we have patient that is 97 years old. So as you can see, we cover wide ranges of upper respiratory infection. It is important to know that 90 to 98% are caused by viruses rather than bacteria. Now, in contrast to upper respiratory infection, we talk about lower respiratory infection, which is below the lung. And we are mostly worried about this more than upper respiratory infection. You are familiar with pneumonia, bronchitis, tuberculosis. Interestingly, cases of tuberculosis from 1992 were decreasing in the United States. Now, from 2021 to 2022, we have close to 1,000 new cases of tuberculosis. At our practice, we see a lot of patients with tuberculosis as well, mostly as part of immigration. One of our providers serve as immigration officer and do healthcare screening. So we are faced with tuberculosis patients, especially in immigrants. Now, lower respiratory tract infection are, if they're progressing, can, of course, you see patients with abdominal pain, nausea, vomiting, and diarrhea. If you look at global burden of disease report, and the last one was 2019, you see that almost 500 million of lower respiratory tract infection leads to 2.5 million deaths. So respiratory tract infection in primary care setting are very important. Now, lower respiratory tract infection clinically we divided in mild or severe. Now, mild are stuffy runny nose, dry cough, low fever, mild sore throat, headache. Severe are the one when you have productive cough, sputum, SOBs, short of breath, chest pain, and wheezing. Of course, lower respiratory tract infection are caused by viruses, bacteria, and fungi. Now, usually you talk about influenza, influenza B, but I wanted to point out that there are more than 200 viruses that cause respiratory tract infection. Usually, people, when you see them, they refer, I came because I have cold. Well, human rhinovirus caused cold, and it was first isolated in 1951 and caused mild infection in adults. Now, the last finding about HRV show that is capable of replication in lower epithelium, causing histological changes in the lung and alveolus, so bronchiolitis and pneumonia. It is interesting that HRV we often see with co-infection with strep pneumonia and Staphylococcus aureus. You are familiar most likely with HEVS. They belong to the Picornaviridae family. We know that there are 7 distinct species. They cause mostly in adult mild symptom, fever, runny nose, sneezing, cough. Sometimes we see patients with skin rash, mouth blister, and myalgia. There are descriptions of, but rare, EV968 enterovirus that caused in cats neurocondition, flaccid myelitis. You are probably more familiar with agents of hand, foot, and mouth disease, mostly in kids, EVA71 and CVA6, although we have seen few cases in adult population of our patient as well. I don't need to use a lot of time about influenza A and influenza B. That's beautiful hemagglutinin presentation of influenza, as you can see. You have to remember that both of them can cause epidemic. However, influenza B is mild and usually cause sporadic. Lately, in Maryland, we have seen few cases of influenza B. The two H1N1 and H3N2 are the one that cause mostly flu infection. We all fear about flu complication, which can be, we have seen patients with rhabdomyolysis, myocarditis, post-influenza infection. Now let's talk about parainfluenza. HPIV is agent of upper respiratory infection, often in cats. Human metapneumovirus cause short of breath, bronchitis, pneumonia. Interestingly, human Boca virus, I'm not sure if you know where name come from, but Boca stands for bovine and canine, and name came from there, Boca virus. It's single-stranded DNA, and it was isolated first time in 2005 from nasopharyngeal aspirate of children. What is interesting is that this virus can persist in a respiratory tract for at least up to 12 months. So we often see reinfection. Now, human adenovirus usually cause in adult population mild respiratory disease. Can cause pneumonia. Mostly, we are afraid when we see patients with immunocompromised immune system. Lately, human adenovirus is not only known in respiratory tract infection, it was connected with wastewater treatment and cause acute hepatitis. So we may be seeing this more and more cases. I'm not going to talk a lot about coronavirus. You heard plenty of coronavirus issues past 3 years. Luckily, May 11 is end of epidemic. Yay! So hopefully we're going to move into good summer with less cases. I've seen maybe past months 2 to 3 cases of coronavirus, and mostly in individuals that were not vaccinated. It's milder than it was in the beginning, and now we have treatment out. So it's slowly dying off. However, when we start to test for coronavirus, we have come across human respiratory or RSV, syncytial virus. So this virus was known prior only in children. However, when we adopt multiplex PCR technology, we were able to pick a lot of adult cases of RSV infection past 2 years. Now, interestingly, when they sequence this RSV, 10 isolate, they have seen that the virus didn't change. It's still the same as it was 10 years. So it wasn't infectivity. We just did not test it in primary care setting adults for RSV infection. So that's kind of interesting. Now, let's talk a little bit about bacterial agent. Now, you know that they cause severe acute pharyngitis. We are afraid of beta hemolytic strep. Neisseria meningitis can cause epiglottitis. Corynebacterium is often a causative agent of otitis or ear infection. Bordetella is known to cause whooping cough. We know that if we have patient that is having co-infection, with virus and bacteria, we see severity of RTS progress and increase mortality as well. In few months from now, we're going to probably hear more about respiratory infection caused by fungi. In primary care setting, respiratory infection by fungus are due to aspergillus, can be blastomyces, and we often see in immunocompromised individual, not in otherwise healthy adults. There are few of them when we see in travelers, especially if they're inhaling the spore of different fungi. They are hard to treat because diagnosis is delayed. It's take a long time to get back any confirmation for fungi, and that does not contribute to good outcome for the patient. Let's talk about benefits, limitation of RTS lab diagnostic, and then move into antibiotic issue. Now, you're familiar, every single test has false positive, false negative. We talk about specificity, we talk about sensitivity, but mostly what we do for respiratory tract infection, rapid testing at point of care, such as rapid strep, rapid flu. These tests take 15 minutes. And then if they are negative, we send for the culture, throat culture, upper respiratory culture, sputum culture. You all are familiar with molecular testing due to the COVID in last 2 years. Now, what we have to remember from all of what I said so far is that RTIs exhibit similar symptoms. So they overlap, symptom overlap. However, they're caused by different pathogens with varying prognosis. Need for right identification of causative pathogen exists. However, diagnostic is delayed. So what would be really benefits of early detection is, of course, rapid patient recovery if you have right agent, and it would prevent unnecessary use of antibiotic, as well prevent antibiotic resistance. In outpatient setting, we can pretty much tell you what is circulating in community, because we are the one that we see patient, and we are the one that transfer patient to hospital setting. So it's important to have good diagnostic to know what agent is circulating, especially when you have community-acquired pneumonia. Now, let's talk about adult antibiotic use. Now, as I said, over more than 200 viruses cause common respiratory infection. So you can say that 90% of the cases are viral. So why are we prescribing antibiotic? During coronavirus epidemic, the use of Z-Pack was encouraged. So it prevents secondary infection from of bacterial pathogen due to decreased immunity. Now, look at what CDC is actually recommending. So it's pretty much common cold or non-specific upper respiratory tract infection should be not treated. So uncomplicated upper respiratory infection are shown that they neither predict bacterial infection or benefit from antibiotic treatment. Now, if you have bronchitis, you know that one of the clinical signs is cough. So we need to rule out pneumonia. However, we often ask patients, do you have colored sputum? What kind of your secretion is? What color it is? It was shown that colored sputum does not indicate bacterial infection. For most cases, chest x-rays is even not recommended. So even if cough persists, antibiotic treatment, according to CDC, is not recommended. So what the CDC suggests is actually use of antihistamine as decongestant and supportive treatment rather than blindly prescribing antibiotic. Now, there are therapeutic guidelines for 2022, when if you see in lavender color, and I'm not Ravens fan, so I did not select that color because of Ravens. But if you can see for acute rhinosinusitis, ABX are rarely required because they're mostly viral. Now, if you have acute otitis media, 80% is spontaneous recovery. However, you have to follow up patient after 72 hours if system persists and gets worse, and then prescribe amoxicillin. Acute pharyngitis or tonsillitis, it depends if patient is on high risk for development acute rheumatic fever or is low risk. So if it's not at high risk, you would need to bring patient back or follow up with the patient and delay antibiotic treatment till you don't get any of proof of etiology of upper respiratory infection. So we all say smart use, careful use is best care. Now, if you look at all of the data in AR, 2.8 million of antibiotic-resistant infection occur each year in the United States. As a result, more than 35,000 people, last reports say 50,000 people die as a result. As you can see, most common pathogens are not viruses, but rather bacterial pathogen. Every single outpatient setting should promote appropriate antibiotic use as part of our clinical practice, and need for antibiotic stewardship exists. Now, antibiotic stewardship is good in hospital setting. In outpatient setting, that doesn't often occur, as you know. We are trying to please patients. Patients are used to have Z-Pak. They are not happy if you don't prescribe antibiotic. So what we can do about that is steps toward antibiotic stewardship. Education, of course. Although we emphasize that antibiotic can be harmful and induce resistance in individual, we need to share the facts always with the patient. We need to promote hand hygiene and infection prevention. We need to really have patients follow instruction and take antibiotic as prescribed. We need to really enlighten patients about adverse drug events. 1 out of 5 ED visits, it's ABX related because of drug events. We need to build in outpatient setting and everywhere too, of course in hospital setting, partnership with the patient, encourage active management of their illness and monitoring follow-up. We need to emphasize importance of adequate nutrition and hydration, especially thinking about 98% of them are viral rather than bacterial, and consider providing so-called care package, so-called non-ABX therapy, start education in the waiting room with videos, CDC, and then posters presentation. So do you have any question for me at this point before we move into host immune response?
So if I was to, so let's say we are really not doing the right thing and we are going to pick an antibiotic. Is there the worst antibiotic to, is amoxicillin a bad choice, or is Z-Pak a bad choice, or you really
okay, so
I mean, if I'm going to use something, should I just pick something, you know what I mean?
Okay, so if I look at really top of prescribing drug in outpatient setting, and I did some research, first is Z-Pak and is Cevdinir. We all know that we are then facing with gastro, diarrhea problem, abdominal pain, adverse reaction. So each of us are afraid of liability and first harm to the patient if we don't prescribe, and then liability attached to the not prescribing antibiotic, right? So amoxicillin is recommended rather than Z-Pak. Now, from my own experience at our practice and our provider, we have Dr. Bala, and we have then 3 nurse practitioner CRNPs. Patient really ask for Z-Pak because it's 3 or 5 days treatment. And if you don't give them Z-Pak, a lot of them are not content. So I would suggest really follow up and delay the treatment at least for 72 hours in order. For example, you have rapid strep and it's negative. You sent out for the culture, right? but culture doesn't come back 72 hours. Even if you send to lab, Quest, whatever lab you're using, you're still without definitive etiology of the agent that is causing. So what we do, we prescribe broad spectrum antibiotic. We know that Z-Pak doesn't really work against gram-negative, correct? It's work against gram-positive bacteria mostly. Does this answer the question?
Yes, thank you.
I have a question.
Yes.
So I understand that, overprescribing antibiotics
If there is, yes.
I was wondering, have you looked at any trends in sort of maybe if there's disparities in different populations of overprescribing antibiotics, and if you've looked at any of the data for sort of like nurse practitioners or physician's assistants who are practicing, if they're maybe overprescribing more than others?
I see what you're saying. Nurse practitioner has different approach, provider as MDs have different approach. But in outpatient setting, you have mostly protocol that we all follow, and it's mostly done with the most experienced provider pretty much. So there is really no differences that I can tell you, at least at our practice.
Okay, thank you.
You're welcome. Any others? Okay, then so far we talk about upper, lower respiratory infection. We talk about agent that cause. We talk about building antibiotic resistance with use and overuse of antibiotic in outpatient setting. And the new finding is, can we use host immune response, innate immunity markers in diagnostic to help distinguish bacterial and viral infection at early point in infection. So Dr. Mo Abuzari, who is here too with us, and I thank him for that, will tell you a little bit more about new technology that is very promising and could be of really clinical importance and utilize 3 host immune response. I'm not going to talk much about, I'm going to just touch basic of these 3 ligands that we are using, protein. It's first one is TRAIL, is cytokine, and it's upregulated as innate immune response to viral infection, basically activate caspase pathway and cause apoptosis on activated T cells and Th1. Second one is CRP. We all know CRP, right? It's connected with vascular inflammation. We see it in ANA patient, RA patient, with insulin resistance, statin therapy, dyslipidemia, hypertension. What's important is that serum CRP values are higher in bacterial versus viral infection. And then the last one is IP10 cytokine, so-called chemokine. It's produced by a variety of cells. You may be familiar, it's kind of calming cytokine storm in COVID infection. So it's expressed in autoimmune diseases too, and it has pro-inflammatory property. So here I'm going to thank you for allowing me to guide you through that, and then giving opportunity to Dr. Mo to introduce